what my job is today is to prepare you in some of the data, the clinical protocols that Tord will talk about in the second part of the presentation, and mine will be very brief, related to my experiences using ankylosing implants over a period of many, many years, not many years, actually maybe 4 or 5 years, and what we've done in our practice and how we've documented our cases. And really, I'm a clinician. I'm a periodontist practicing in North Florida. And in my practice, using very many implants over many, many years, it's clear that we have some designs today that are used in specific purposes. For instance, we have implant systems that are supragingival designs where they're intending to put a crown margin supragingivally. And we have other implant systems, of course, that we all use that are crestal implants, implants that are really designed for that purpose. Unfortunately, some of these designs, and much of it has been talked about today by some of the really, really good speakers we've had, are used in situations where they're placed subcrestal. And that subcrestal situation obviously can lead to some disasters. Not always, but many times can lead to disasters that no one wants to see and become real problematic for our patient care. Implants that are designed to be supracrestal sometimes are put in situations where they're placed at a crestal position or in the wrong biotype, and the disasters associated with that are pretty obvious. Additionally, day-to-day perio practice, day-to-day my practice, dealing with a constant treatment of our patients, trying to get an inflammation-free environment, we see these issues all the time. And implant systems via the microgap and other issues related to inflammation, some of these cases are obviously considered clinically successful. But are they really clinically successful? Because on a day-to-day basis, looking at chronic inflammation, we may have issues related to that. So in our work, our intention was to look at the stability and health related to subosseous placement of ankylosing implants. And really looking at a retrospective study, we're really kind of stating the obvious that many of us have already known. This implant system can be placed subosseously with very successful, predictable, and stable results. And that really was our mission. Because if we were able to place a subosseous implant predictably, there are lots of benefits associated with that. We could have long-term tissue health stability, obviously. The opportunity to place implants side by side and maybe closer and more predictably than we have with any other system. We may be able to mask metal, or even better, if we're using zirconia abutments, have the opportunity to have abutments that emerge from below bone to really, really maximize aesthetics. So what we did is we went backwards. We looked back into my cases, and over a number of years, hundreds of ankylosing cases, where I used a consistent protocol, and that was to place virtually every ankylosing implant subosseously. And really, asking this question, is this design possible to leading to bone stability? And I go back to George Romanos, who told me years ago, this is a subosseous implant. And his work and others have shown us that with a coated surface on the coronal aspect and a fabulous abutment implant interface that essentially leads to a one solid implant, that maybe this is achievable and maybe it's sustainable. So I'm interested in my practice in tissue health, and I'm interested in bone stability over time. So when I look at my cases, and I follow my cases over years, and this is essentially going to be, as Tord talks about, a radiographic study. Cases involve immediate extractions, abutment placement, implant places, and follow-up. These are cases that we consistently did over a period of years. Side-by-side implants, extracted side implants, and you'll notice that, and this has been discussed earlier by some of the speakers, that I really like to put abutments in, and many times I'll put abutments in at time of surgical placement, but if I don't, I will put in gingival formers that essentially have a virtual same shape as the abutments. So, and you can see in this case was done with gingival formers. Virtually every case that I've done has been done as a one-stage. Some of them have been grafted at time of surgery, but every one of them is a one-stage, and there was no two-stage surgeries done with any of these cases. And more examples of the kind of cases. It's interesting to see this, hear the statistics that in reality of my practice really represents and reflects these national statistics, that most of my cases are single-tooth cases. Another example of a type of case that we do, subosseous placement and follow-up over a couple of years later. And this involves also posterior cases posterior cases, side-by-side cases, and cases restored with zirconia abutments, cases restored with metal abutments. Anterior, lower anterior cases, and typical type of cases that Tord will talk about in his data crunching. In surgical protocol, again, all cases were done as a one-stage case. Every case was done with at least a 1 to 2 millimeter subosseous subcrestal placement, which I question a little bit, and I'd like to talk about a little bit later, that maybe the variability of subosseous placement is something that we can examine in the future. Every restoration was done a minimum of 3 months post-insertion. Every case was followed for a year. A lot of cases were immediately provisionalized. Balanced abutments were used in most anterior cases, although some of them were done with stock solid abutments. Now, the variability of subosseous placement is an interesting thing, because if you have an implant system that can be placed subosseously, you may be able to manipulate that as you consider a deeper placement or a shallower placement if indeed you're placing a stock balanced abutment at time of surgery. And I've used this feature many times because, as I'll talk about in a second, I work in reverse. Every case, whether I'm putting an abutment on at time of surgery or I'm going to delay the abutment placement, I will have an abutment present and try it in. And if it works and I can use a stock abutment to achieve the aesthetic goals I'm looking for, then I will place it, or I will delay placement, or I will change the position of the implant in terms of depth to be able to achieve what I'm trying to do. And again, a little different thing about the way I practice, because even though I'm a periodontist, and even though I practice in a conventional situation, all my cases are done at the abutment level. So the restorative dentists that I work with are going to get the case at the abutment level rather than taking impressions at implant level. And to me, it's very, very important for me to manipulate tissue, to control provisionals, to control papilla health, emergence profiles. And I do this by establishing an abutment level impression protocol. So when I think about what I do in my practice on a day-to-day basis, I look at an implant, ankylosing implant, and the abutment, and the restoration in 3 parts. One, I'm always thinking about subosseous placement and the variability of that. 2, I look at the abutment as a transition component. Essentially, my goal is to establish a margin of a balanced abutment to match the CEJ of the adjacent teeth. This is on a radiographic level. So that I can choose an angle or height or type of abutment so that it can be restored to optimum level. So 3 components: implant, transition, and margin. And I look at those 3 as one piece on every case that I do, particularly on terms of an anterior aesthetic case. Posteriorly, this is some of the surgical cases that we're going to be evaluated in the study. Typical subosseous placement. This is a case with gingival formers. After healing, the quality of the tissue is self-evident, stock abutments, and restoration. Radiographically, initial implant placement, and final restoration. Really was no need to splint these cases together, but the restorative dentist did it. And yes, I did remove that cement on the distal of that tooth. Typical anterior placement, and most of the anterior cases are going to be done as one stage, and many, many are going to be done as a flapless procedure. Some of the protocols that were talked about today, placement of an implant in a palatal position, angulating the implant to follow the appropriate anatomy, very specific measurements that I took at every case in terms of my osseous position, especially when you're doing flapless surgery. Being very meticulous and understanding the position of bone is a real challenge between sounding a bone with a needle and using periodontal probes and really assessing where your bone is. These criteria are very, very important. A little unusual. I'm a periodontist that makes a lot of provisionals. In this case, I intentionally made it under contoured, and I do that frequently using emergence profiles that Henry talked about. And eventually it was restored conventionally and with a very good result. Another case, typical of the cases that we'll talk about, fractured tooth, very attractive young lady, snapped a tooth off. This case was done as an immediate with a provisional. Unusual that most of my cases are done with ankylose A rather than B, but this is a rarity where a B was used, and you can see on the far right the final restoration. Interesting story behind this young lady. She comes into her dentist about a month after the restoration was done, and the dentist instantly sees that the mesial incisal porcelain had broken, and he's dying because he's very meticulous, very caring. He knows he's got to replace his crown. And he's sweating, and she says to him, you know, Doc, you may have noticed that that little incisal edge is cracked on the mesial, but I got to tell you, it looks really, really natural, and I think it really looks good, and I think we should keep it. And he goes, you know, I really agree with you. True story. So anyway, we've talked a lot about platform switching today, and I have a little point on that, and I don't really know if you're dealing with an ankylose design with the type of connection, the coated top of the implant, that this is really, really platform switching. This is essentially a one-piece implant, and that we've medialized the connection, but if there is very little irritation, as a matter of fact, virtually no irritation, no inflammation, that are we really talking about platform switching, or are we talking about just flat a better design, a better implant abutment design intentionally for a subosseous placement? And yes, I think one of my questions is the optimum implant depth. Where do we put it? Can we vary it? Because one of the things that we see empirically is that sometimes the deeper the placement, the better the outcome. Anyway, it's time to bring in Tord. I thank you very much for your time, and I really appreciate this great meeting and dentistry.